Today we're going to talk about the diabetic foot. What about its identification, diagnosis, and management? Our objectives, as you are as a general practitioner, you will need to know how to define the diabetic foot, when to screen, how to screen, and principle for patient education. Definition of diabetic foot is any foot pathology that results directly from diabetes or its long-term complication. So we don't need to wait until the patient have an ulcer or amputation or severe infection to say this patient have a diabetic foot. Just the patient could have sensory neuropathy, and this is a diabetic foot, and it doesn't show anything at the patient. So we need to know that any pathology related to diabetes, this is what we call a diabetic foot. Before we start talking clinically, we need to know some background for the pathogenesis of diabetic foot. There are 4 items for pathogenesis: peripheral neuropathy, peripheral arterial disease. Diabetic patient is more prone to infection and trauma. First, neuropathy, peripheral neuropathy. First is sensory neuropathy. Diabetic patient is more liable to have decreased pain and the proprioceptive sensation. So loss of this pain and this proprioceptive sensation will lead the patient to have more injuries. This is a picture of a patient who have injury in his foot, and he didn't recognize it until he just discovered he have blood on his foot. This is another injured patient, and he didn't find any feel anything, just discover this injury. This is a patient with burn injury due to riding a motorcycle, and he just discovered this first-degree burn accidentally. And this is also a second-degree burn related to hot water that the patient tried to put his feet in the tub, and he didn't feel the temperature, so he just had this burn on his foot. The second manifestation of peripheral neuropathy is the motor neuropathy. Motor neuropathy resulted in small muscle wasting, leading to foot deformity. Foot deformity, one of the most manifestation of small wasting, muscle wasting, is that this type of deformity, this is called the claw toe or the hammer toe, and this is a arched foot. I would like to concentrate here that whatever the cause of the deformity, if it is due to motor neuropathy or it is just some people have the deformity, just was born with this type of deformity, which is present, the motor neuropathy or non-motor neuropathy related deformity, both are high risk for the diabetic patient, because the deformity will lead to pressure points, as we see here in this patient, pressure points related to the areas, the metatarsal head and heel, and will lead to later on to increase the foot pressure, will cause callus formation. Callus, which is the hardening of the skin, this will cause more compression on the underlying tissue. The last type of peripheral neuropathy is the autonomic neuropathy. Of course, many of us know about the autonomic neuropathy, central autonomic neuropathy related to diabetes, like abnormalities in the pulse, like the diarrhea and different other types. But here we are talking about the peripheral autonomic neuropathy. Peripheral autonomic neuropathy will lead to dryness of the skin and fissuring of the skin, like this case, and these fissures will be the cause for introduction of secondary bacterial infection. As we see here, we have to take care of the dry skin. So having all this peripheral neuropathy, sensory, motor, and autonomic together will lead to the formation of the neuropathic ulcer. The second risk factor is the peripheral arterial disease. The foot at risk, of course, peripheral arterial disease will put the patient foot at risk for ischemic ulcer, and it's an ulcer at the most extreme peripheral part of the other pathogenesis is the diabetic patient. Of course, is more prone to infection due to immunity affection, and the diabetic patient is more prone to trauma. More prone to trauma because of his eye disease. The patient cannot see. Sometimes he wakes up at the night and he's just going to the bathroom and so on, will lead to marked trauma. More liable to trauma because the loss of the perceptive or deep sensation. So the patient have disequilibrium and more liable to falls. So now we know about the pathogenesis of diabetic foot. We need to move on to when to screen the diabetic foot. As a general practitioner, it's one of your job to screen the patient. This is the main job of a GP, is to screen, know what to do, when to screen, and how to screen for everything related to diabetes and medicine as a whole. For this topic today, we'll talk about patient for diabetes. For prevention of diabetic foot, one of the major points is the regular inspection and examination of the foot. All type 2 diabetic patients should be examined at first presentation, then at least once a year. So we all know that type 2 diabetes is not related, didn't happen today. If the patient is diagnosed today with diabetes, he's probably have insulin resistance and even diabetes without clinical manifestation for many years before. So when you just discover the patient to have diabetes, you need to examine the patient at first presentation, then at least once a year. At least once a year. By the end, we'll know how about the risk stratification and when we should examine the patient. The patient with risk factor should be examined every 1 to 6 months according to the degree of risk categorization. We should know that absence of symptoms doesn't mean that the feet are healthy. We all know that patient could be very with neuropathy or early peripheral arterial disease and he doesn't have any symptom. And we should examine the patient on lying down and on standing up because some deformities and sometimes the gait affection, you have to see it while the patient is walking. And shoes and socks should be inspected. This is part of your screening and this is part of your sheet that you're going to put into the items about the screening of diabetic patient is shoes and socks, because this is a very cornerstone in the causes of foot ulceration in diabetic patients. Now we know when to screen, how to do. Foot screening involves 6 major items. We need to examine the nail, examine for deformities, examine the skin, neurological assessment, vascular assessment, and as we said before, lastly is footwear assessment. Examining the nail, we should know that there is nothing such a trivial lesion in a diabetic patient. So we need to, in examination of the nail for different other diseases, we can think about the nail, like the color of the nail, like the clubbing of the nail, and different other categories. But here we should think even by the very minor changes of the nail, like thickening of the nail, having too long nail, ingrowing of nail, presence of fungal infection, and wrongly cut. For this patient, this is thickening, manifestation of thick nail and too long nail. Thickening of the nail can cause pressure on the other toes, or even on the deep structure of this toe. And also the too long nail can cause injury to the neighboring toes. Thickening of the nail could be either due to autonomic neuropathy or it could be due to fungal infection. In growing of nails, like you see, the nail edge will grow vertical rather than horizontal, and skin at the nail edge become thickened and become hardened and cause entry of the super added secondary bacterial infection and leading to injury. In growing of nail is very important to be managed abruptly in patient with diabetes. We don't have to wait or give time to the patient, because it could lead to devastating infection and could cause the patient his toe. For wrongly cut nail, as we see here, this is the way that we should cut the nail. Cutting the nail should be straight line. We should leave part of the few millimeters of the nail beyond the nail bed, and we should not cut the angles of the nail. Like we see here, this is one manifestation of the wrongly cut nail, and this patient did overcut the nail, and this is very wrong, because our patient could have loss of sensation, so the patient can injure himself. And we need to tell our patient that if he have a problem with vision, or the patient is cannot bend to cut his nail, he should get some assistance from his relative, or just ask for assistance from a diabetic foot clinic. Fungal infection, like this chalky white appearance, could come into the angle or in the distal part of the nail or in the lower part of the nail. And fungal infection is one of the nail is one of the resistant infection, and it needs long time treatment. This dystrophic nail, this is one of the manifestation of fungal infection. After finishing examining the nail, next we move to deformities. And as we said before, whether deformity is due to diabetes or not due to diabetes, it's a risk factor. So we should document it and try to find a way to prevent its effect on the diabetic patient. This slide shows the load transmission in the foot. This means when you walk barefooted on the floor, the first part of your foot will face the floor is your heel, then the lateral aspect of the foot, then the crossing to the medial aspect of the foot, and the last part of your foot to be related to the ground will be your big toe. The big toe have a special characteristic that it should be extended for 90 degrees and to help you to take the next stance. Stance means a step, to take the next step of your walking. Any abnormalities of your deformity will seriously interfere with the normal load transmission, like this, with the normal biomechanics of your foot, so will lead to abnormalities and pressure points in this patient. One of the commonest deformity is the hallux valgus. Hallux valgus means lateral deviation of the big toe, leading to more prominence of the head of the metatarsal. This is an extreme degree of the big toe of the hallux valgus, and this is, as we see, this is a different pictures of cases of hallux valgus, and by the end we see this is a severe degree of hallux valgus. What happens here is the big toe will move laterally, deviated laterally, and leading to prominence of the head of the metatarsal, leading to more pressure in this area on wearing the shoes, will cause bunion. The thickening of the skin here is called bunion, and later on, and could be the overcrowding of the toes will lead to this what's called the kissing ulcer, when the friction between the big toe and the second 2. So this is the most common areas for ulceration in the patient with hallux valgus. The hammer 2 is a condition where there is flexion of the interphalangeal joint and dorsiflexion of the metatarsophalangeal joint. So this is where we're going to have here, see this interphalangeal joint, the skin overlying the interphalangeal joint will be thickened, appearance of calyces, and later on will end in ulceration opposite this callus. These are different manifestation of the hammer 2. Another type of deformity is the hallux rigidus. As we said before, the big toe should be very flexible and should get extension 90 degree when you are walking. Hallux rigidus is one type of deformity. It means rigidity of the big toe and cannot do what's expected from it to get the 90 degree extension. So what's going to happen that the patient will get pressure all the time on this area, leading to calyces and later on ulceration. Hallux rigidus is only related to disease, so it can happen in diabetes, can happen in rheumatoid arthritis. So it's a disease affecting the soft tissue. It doesn't happen in a normal population. This is the ulcer related to hallux rigidus and thickening of the skin at this area. Another type related to foot deformity is the Charcot foot. What we used to know about the Charcot foot is that it's a major deformity in the foot, leading to the foot to be a bag of bone with loss of architecture between the tendon and joint and so on. But nowadays it was discovered that the Charcot foot is a neuro-osteoarthropathy, so it's a combination between neuropathy, osteopathy, and affection of the joint as arthropathy. This effect related to diabetes have two stages. The first stage, the foot will be only warm, swollen, with temperature difference more than 2 degrees centigrade between both feet. Later on, this patient will resolve, this inflammatory phase will resolve, ending in a chronic stage where the temperature will subside. The acute stage is similar to that, like the patient with hot swollen foot, like with differential diagnosis, patient with deep venous thrombosis, patient with gouty arthritis, patient with cellulitis, and so on. So we should put in our differential diagnosis the acute stage. Why it's important to define the patient at the acute stage? It's important because the patient, if we manage the patient properly in the acute stage, he will be transmitted into the chronic stage without deformity. The dangerous part of the Charcot foot is that we will get to the rocker bottom deformity. This is a picture of a diabetic of a patient of Charcot foot. As you see, just a swollen and hot foot. This is also just swollen and hot ankle. As you see, this is a patient after transforming into the chronic stage with the rocker bottom deformity. The presence of rocker bottom deformity and the loss of the longitudinal arch of the patient and this prominent part in the arch, leading to patient walking all the time on his arch instead of being away from the floor, leading to callus formation at this area. We should never have this pressure area, leading to the formation of ulceration at this typical site. Now we screen the patient for nail deformities, and now we're going to look at the skin. Examining the skin should include looking for calluses, looking for bunions, looking for redness and worms for infection, fissure and dryness for autonomic neuropathy, looking for swelling like edema, presence of maceration for fungal infection, and of course looking for foot ulceration. So this is dryness of the skin related to autonomic neuropathy, and this is a case of the callus at the head of the metatarsals, and this is a corn at the little toe, one type of hardening of the skin related to pressure also. We look for the interdigital tenia pedis, for between the toes, looking for tenia pedis. Tenia pedis could occur either in between the toes or related to the nail. Look for edema lower limb. Manifestation of edema, of course, the overlying skin may be smooth and shiny with loss of normal skin wrinkle, and dorsal toes joint creases is lost. Dorsal toes extensor tendon appearance is lost, and distinct edge of the medial malleoli is also callus. And this is another type of callus. As we see here, we sometimes see this area for callus, and it's not related. We all know that it shouldn't be. This is not a normal pressure site, but actually in Islamic countries and in rural areas, we see this area, this site of callus formation leading to ulceration because of the sitting for prayer, for tashahhud, and sometimes old women in rural areas just sit on the Arabic couch, and with this with the abduction of the foot like this, lateral rotation, sorry, for the foot, and having pressure all the time. If we see this, we should instruct our patient, please don't you don't have to sit like this, and you have to change your position of sitting. And of course, by examining the skin, we need to assess for diabetic foot ulcer. Looking for diabetic foot ulcer, we have to comment to either a foot ulcer, what's the type of the ulcer, and is it infected or not. As we said before, we have two types of foot ulcer. It could be a neuropathic ulcer, and the other type is ischemic ulcer. For the neuropathic ulcer, it is usually in the under the metatarsal head or any pressure areas like the tip or the dorsum of the toes and heels. The most characteristic of the neuropathic ulcer that it is painless, surrounded by this whitish area of calluses, thickening of the skin, and it has a punched out edges, and it penetrates deeply to involve the deeper structures. While this is where we usually see the neuropathic ulcer. This is a neuropathic ulcer related to the patient having deformity claw toe. This is a neuropathic ulcer related to shark foot, and this is a neuropathic ulcer related to hallux rigidus. For the ischemic ulcer site is different. It's related to the edge of the foot or the toes. It is the most extreme distal part of the foot, related to the poorest blood supply. It's painful because ischemia is a painful condition, except if it is associated with peripheral neuropathy. We don't have here a callus like the neuropathic ulcer. We surrounded by a rim. Here it's surrounded by a rim of erythema, and it's often associated with other manifestation of ischemia like loss of hair, like dystrophy of the skin, and so on. Now we know the type of diabetic foot ulcer. Next, we should diagnose if it is infected or not. It's important to know if the patient has an infection in his diabetic foot ulcer. Of course, purulent secretion is an obvious character of infection. If we see pus, so it is infected. Sometimes not pus, but two or more local signs or symptoms of inflammation like redness, worms, induration, pain, or tenderness suggest the foot is infected. like here we have redness and we cannot feel it, but it should be warm. Systemic signs of infection like fever, chills, leukocytosis means a severe infection. Here just one hint we should know. Please, if you see a patient with diabetic foot ulcer and you suspect that is a severe kind of infection with systemic manifestation, please inform the patient to get to hospital. This patient need hospitalization and need intravenous antibiotic injection, so he needs more care, not an outpatient case. The next item in examining the foot is the neurological assessment. Neurological assessment, like neurological assessment as a whole, but here we add some points. For inspection of a neurological assessment, as we said, we look for the muscle atrophy, motor neuropathy. We look for the triskin for autonomic. We look for dilated vein with a little bit warm foot. This is one of the manifestations of autonomic. What we are going to use to assess patient, as we see here, these are our instruments for examining a patient with neuropathy. For neuropathy, first we look for the vibration sense. Vibration sense, we use tuning fork 128, and we can use an instrument called the neurosciometer. For the tuning fork, this is different from that we use in the hearing test. This is 128. We should carry it and strike it and then hold it against a bony prominence. What we do, we put it on the medial aspect of the first metatarsal joint. We can put it on the plantar hallux and medial and lateral malleolus. If the patient cannot feel distally, then we move more progress. This is where we have areas where we put the tuning fork. Another instrument is the neurosciometer. Neurosciometer, we don't use it for screening. It's just an apparatus. We use it for mostly for research, and it needs a well-equipped clinic to use it. Just to use the tuning fork is enough for foot screening, and we put it on the same sites where we use for the tuning fork. The next is using the pressure perception, the loss of pressure. This is what we use is the monofilament, 10 gram monofilament. The 10 gram monofilament is just a small device like this with different shapes. We use one filament. This is calibrated. When we press on the skin like this, it will put pressure of 10 gram on this skin. As any neurological assessment, we should teach our patient first. So we should apply the monofilament on the patient hand or elbow or forehead, just to let him teach the patient what we are going to look for. Then we put it perpendicular on the skin and put some pressure on it until it is slightly bent, as we see. We should ask the patient to close his eyes and ask him if he feels this pressure. If an area having callus or ulcer or scar or necrotic tissue, please don't put the monofilament on it, because it will give you a false result. Where to put it on the skin? This is some areas where we can say we put it on these four areas. But recently, the International Working Group Practice Guidelines just said 3 points are enough. Protective sensation is present at each site if the patient correctly answers on 2 out of 3. So we ask him, we put pressure on these 3 areas. If he can feel 2 of them, so he is okay. If he can feel only 1, so he is not okay, and he has a loss of pressure sense. Then we look for test for superficial pain sensation. For the patient to have neuropathy, peripheral neuropathy, pain sensation should be lost at with a sensory level, bilateral, symmetrical affection, as you see, bilateral symmetrical affection involving both hand and feet. Of course, loss pain sensation and loss of sensation in a diabetic patient could be related to other causes, but here to be preferably related to peripheral neuropathy, actually the foot should be affected first, because the long nerves are affected earlier than the shorter nerves in peripheral neuropathy. So if we have this patient having affection of his hand first, please look for other causes than just peripheral neuropathy, but foot should be affected first. Then we look for touch sensation. Next, we examine for temperature assessment. We can do the temperature assessment. We need to tell the patient if he can differentiate between warm and cold. And this is important because one of the major cause of injury in diabetic patient today is that he get injured by warm water, as we said before. So this is one instrument. It's called the tip therm. The tip therm is just a rod like this, with one side of it is plastic where it is warm all the time, and the other side made of a substance which is mostly cold most of all the time. So we tell the patient, do you feel this is this cold or warm? And if the patient cannot distinguish between them, we should more educate him about how to take care of his feet. Then this is how we test the proprioceptive sensation. Look for the sense of position, sense of movement for different and lastly, we do the patellar reflex and ankle reflex. Of course, the ankle reflex is affected first due to peripheral neuropathy. And please, we don't need to wait until the patient coming to you with loss of ankle reflex, because this is a very late condition. We need in our patient, this is our aim from the screening, is to detect our patient very early before he gets even loss, just as he gets the loss of protective sensation, to protect him from the different types of injuries related of this loss of protective sensation. The next assessment is a vascular assessment. Vascular assessment, the patient either come without any complaint or coming to you with intermittent claudication. Intermittent claudication means the patient comes to you with pain. The pain is cramping pain, mainly in the cuff area, and it is related to walking and relieved by rest. So this is the main characteristics of it. Of course, it can happen in different areas. It can happen in the thigh, it can happen in the buttocks, but mainly in the cuff area. But intermittent claudication, the walking distance before the patient get this pain is very important, because the longer the walking distance, this is a better condition, and the shorter the walking distance means the patient is getting into severe peripheral arterial disease. The presence of resting pain means that the condition is more severe. On inspection, we look for color changes, and then we put our hand to look for cold extremities, shiny atrophic skin, look for loss of hair and absent pulsation. Color of the foot, any change in the color of the foot can be related to ischemia, as you see from pink, cyanotic, hyperemic, pallor, and of course we don't wait until we get this color. Color change is related to position. As we see, one test is elevating the limb. In a patient with vascular affection, elevating of the limb will cause severe pallor of this limb. And putting the limb in independent position but without touching the floor will cause this rubor color, dependent rubor related to this ischemia. Then we test for the temperature difference between the two limbs, but please try to get the foot exposed, the limbs exposed to the room temperature before you do this test. Next, we do the capillary fill test. Pressure on the pressure on the nail will get pallor and should be within seconds when you remove the pressure that the nail get its color back. But if we retain this pallor for a few seconds here more, this means that the patient have peripheral vasculitis. Then we test for the pedal pulse, testing for the dorsalis pedis. If we cannot feel the dorsalis pedis, we'll move upward to test, look for the posterior tibia behind the medial malleolus. If we cannot feel it, we have to think that it can happen in healthy individual. Absent dorsalis pedis occur in 8% of healthy individual, and absent of posterior tibial pulse can occur in 2% of the population. So if we don't feel it, we need to move to the next level of we do the Doppler ultrasound. Using the Doppler ultrasound, this is the type of wave as we see. It should be for normal Doppler ultrasound, we should have triphasic wave. This is the only normal finding, is a triphasic wave. The upper one is the triphasic wave. If we find the biphasic or the monophasic wave, this means we have different degrees of peripheral vascular disease. Of course, and if we don't have any wave, this means a severe degree of peripheral arterial disease. Another test for peripheral arterial disease is we do the ankle brachial pressure index. The ankle brachial pressure index means that we measure the systolic blood pressure, the brachial systolic blood pressure, and we measure the ankle systolic blood pressure, and we divide them, so we get the ankle brachial index. For normal ankle brachial index is from 0.98 to 1.3. This is the normal. The lower it gets for the ankle brachial pressure, this means that the patient having more severe degree of peripheral arterial disease. And on the other hand, having the ankle brachial pressure more than 1.3, this means the patient having atherosclerosis and false positive reading, and we cannot depend on this test. Now that we examine the nail, deformities, skin, neurological assessment, vascular assessment, we move to examining the footwear assessment. For a proper footwear for a diabetic patient, the patient should have a shoes with wide toe box, and should have the upper sole become some kind of elastic upper sole, and the lower part of the foot should be hard and have a rocker bottom for easier movement. The inner side of the shoes should be seamless. Seamless means that no protrusions or no sutures and so on inside the shoes that will affect the foot, and it should be well fitted to the patient, either by Velcro or by shoes lace. So, what do you think about these shoes? Is this shoes a proper shoes for the patient, or it's not a proper shoes of the patient? To get our idea about it is proper or not, have this picture. This patient with this very nice shoes, as you see here, it doesn't have the wide toe boxes that we have. It moves more pointed, leading to overcrowding of the toes within the shoes, leading to pressure on the toes. And this is very dangerous for the diabetic patient, because, as we say, the patient doesn't have the proper feeling, so it can have this pressure and just discover by the end of the day that he's having some bully and having some very serious condition of his feet. This one type of a bad shoes, as we see, this is the lower part of the shoe. First, the inner sole here, this is one bad type which causes pressure on the foot of the patient, and the lower aspect of the shoes is very weak, that it can be penetrated by the rocks from the ground. We should examine the foot and look inside the shoes. You would never think what you can see in a shoes of a diabetic patient like this. Sometimes this is a pencil embedded in the shoes and the patient doesn't feel it. Sometimes we find the drugs, the pills of the patient inside the shoes and the patient didn't feel it. So we have different types of things that we have to inspect. So we should tell our patient to look inside his shoes every morning. Now that we finished the examination and we finished the screening of our patient, we have to risk stratify our patient. Risk stratify to find is it a risky patient or not a risky patient. If the patient have no LOPS, LOPS is loss of protective sensation, is the pressure sense, and he had no peripheral neuropathy and have no peripheral arterial disease, so he have a very low risk of foot ulceration. This patient can be examined once a year, as we said before. If the patient have loss of protective sensation or peripheral arterial disease, so this patient have a low risk for ulceration, and this patient we can examine him every 6 to 12 months. If the patient have both peripheral neuropathy and peripheral arterial disease, or have peripheral neuropathy with foot deformity or peripheral arterial disease with foot deformity, this is a moderate risk patient, and this patient should be examined every 3 to 6 months. This same patient will be high risk if he has history of foot ulceration, history of lower extremity amputation, and end-stage renal disease. If the patient have any one of these three items, so this patient should be examined every 1 to 3 months. This means that even if the patient is not complaining of anything, he should come back to you for your clinic to be re-examined for examination. So this is a summary of the framework for diabetic foot examination. Inspect for color, ulceration, dryness, callus formation, look for infection, look for injury, evidence of injury of the shoes, and look for Charcot joint. Always put it in your mind. Neurological examination with the 10-gram monofilament with one of these tests, like touch, pin sensation, vibration sense, and joint position sense, and examine the circulation for peripheral pulsation, temperature, capillary filling, and please don't forget to examine the patient's shoes. As you're a general practitioner, one of your main job is to educate your patient. Your main job is prevention, so you need to educate your patient. This is some instructions that we have in the Diabetic Foot Clinic in Mansoura University about how to educate your patient. You need to ask your patient to check his foot by his hand first and look inside it to see if he has something inside the shoes. He has to check his feet daily and in between his toes, either by himself or any one of the family. If he cannot see, he can use a mirror to examine his foot. Always wash your feet with tap water. Don't soak it. Just wash it and dry it thoroughly in between the toes. Dryness is very important to prevent fungal infection. Always cut their nail properly, as we said, with straight line, and do not cut the sides of the nail. Use emollient once or twice a day to prevent this dry skin, but never use the emollient in between the toes. Always wear cotton socks and avoid to have any should be seamless from the inside. Make sure that it doesn't have any suturing from inside. Choose the proper shoes and never to use chemicals or sharp objects to remove calluses from the skin, and never to put their feet in water before they make sure of the temperature. Of course, never ever to walk barefooted, and don't forget to measure preventative measures, that to have their blood glucose level within normal, and avoid smoking. High blood glucose and smoking will cause more affection of the nervous neuropathy and more peripheral arterial disease. And tell your patient if he finds any of these manifestations, he should get directly to the nearest diabetic foot clinic. My reference for this topic was the International Working Group of Diabetic Foot Guidelines 2019. Please, if you want to add to your knowledge, you can get it online. It's available for free, and thank you.